My name is Sudha Jayaraman. I'm a trauma surgeon at the University of Utah, and I'm presenting on my project, which is developing a sustainable master's track in global health innovation. Global health and innovation are unlikely partners. In fact, clinicians engaged in global health are often unable to access formal training in global health, not to mention in innovation. And those involved in innovation training often are focused on people and problems in high-income countries. This leads to priorities and funding and solutions to address global health coming from outside experts who don't always have a good sense of the local problems, constraints, or processes needed to implement change. Furthermore, this leads to unintentional exclusion. Why? Because those that need access to global health and innovation training are often not able to access that training due to travel and other commitments. In fact, if you look at where global health education is available, it's largely in Europe and North America, which means most of the rest of the world is not able to access this and certainly not able to afford it. This especially affects those that are working in global health, especially women and those with families who can't travel all the way across the world to acquire this content expertise. This leads to a mismatch. Those in high-income countries have the resources, investors, and programs to think about global health problems, but those that are familiar with the problems and have ideas of solutions and are context experts are in low and middle income countries. As we know, problem solving in global health requires that in-depth familiarity with healthcare systems around the world and real world constraints and expertise in a variety of different fields. It also requires interprofessional collaboration and mentorship and resources, but these are quite often not available to those in low and middle income countries. At the University of Utah over the last year and a half, I've been working on this as an opportunity to build on our success. We have developed an impressive innovation culture that's very well known regionally and have long-standing global partnerships. In fact, I've joined the Center for Global Surgery at the University of Utah, which is the oldest such center in the US. There are numerous partnerships across our domestic environment as well as the global settings, including the Utah Asia campus and our partnership with Ensign Global College in Ghana, which we can leverage along with a robust bench-to-bedside program that's run by our Center for Medical Innovation and leads innovation domestically across the state. We also have an impressive innovation ecosystem that allows us to think differently about innovation training. We've worked on developing a master's track in global health innovation and technology that draws on all of these strengths, from global health policy and health systems to human-centered design and research methodology, to create a equal level collaboration, both in the design of the program and in terms of who would participate in it. We're planning on launching this later this year and have created it to be specifically a hybrid and modular program that includes significant asynchronous component so that we can recruit participants from around the world who can then participate in practical projects that are valuable skills for them to take back to their own communities. We aim for this to be a multidisciplinary, interprofessional degree program with a small starting cohort of 6 students later this fall. Our emphasis with this program is on global, on addressing global problems, but through global participants taking the lead. We aim to intentionally recruit those from low and middle income countries with full funding support and recruit women clinicians in global health through the WomenLift network. Ultimately, we aim to create a global network of experts who have context expertise and the problem-solving skills needed to lead in their communities. Thank you so much.